Very good morning, ladies and gentlemen, beloved teachers and colleagues. I'd like to extend a warm welcome to all of you as we begin today's exciting lecture on the subject of leprosy. It's one of the oldest diseases that mankind has ever known. It is also one of the most prevalent social diseases. Just before going into the presentation, I wanted to quickly remind all of my friends about the basic housekeeping guidelines. As all of you know, that this webinar link will be available from 9 a.m. up until only 9:45 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guideline. This is to improve and also to maintain the standards of the CPD program conducted by Shri. We thank all of you for joining us with us today. And also, I wanted to remind you all about if there is any power failure or if you disconnected from us, we will send you a number. Please do call to that number and we will check and reconnect you back to the lecture. Let's move on and go to today's presenter, Dr. Kahavita. She's a consultant dermatologist from the Anti-Leprosy Campaign. She is the immediate past president of the Sri Lanka College of Dermatologists and also a member of WHO Technical Advisory Group for Leprosy. She was the secretary for the Sri Lanka College of Dermatologists from 2012 to 2015. And also, she was a chairperson of Leprosy Study Group of the Sri Lanka College of Dermatologists. She was an ex-co member of South Asian Regional Association of Dermatology, Venereology, and also leprosy. She has authored 3 books and guidelines on leprosy, as well as she has several international and national publications on leprosy and leishmaniasis. Dr. Kahavita, she has made us Sri Lankans proud by giving various presentations on leprosy and leishmaniasis on numerous international venues. There is no one who is more qualified to provide insight into the topic at hand today. So, Dr. Indira Kahavita, Madam, I would like to cordially invite you to give us your wisdom from now. Thank you very much.
Thank you for that kind introduction. So, today, rather than having a formal lecture, I thought we will first go through a few cases of varying presentations of leprosy and then go to a general discussion about leprosy. But before we begin, I would like to tell you why we are talking about leprosy these days. Because the prevalence of leprosy, the number of cases that we have been detecting over the past 3 years has been less than what we would have expected or what we would have been happy to have. This was like we had been seeing about 1,600 to 2,000 patients per year since the year 2000, but last 3 years with the COVID pandemic and the resultant issues in the general healthcare services, we have been seeing less numbers, around 1,000 cases. So these hidden cases are very important, especially because leprosy is an infectious disease, and the cases that are not treated, those patients serve as reservoirs of infection to the society. Secondly, those patients who have been missed and who have been incubating the disease without being diagnosed and treated, they are at a higher risk to develop neurological impact. So again, they will be a problem to themselves and to their families as well as to the society, because we will need to look after them we will need to look after them as they are disabled neurologically. So because of that, we are trying our level best to make the society aware, especially the healthcare workers, as well as the general public, about leprosy. So we will move on to the cases. Before we move on, I will just give you a general outline of leprosy. Leprosy is a chronic infection of the skin and peripheral nerves. In the questions, there was a query, does it affect the CNS? No, it doesn't. So we would not consider a patient with in a patient with stroke or paraplegia, we would not consider leprosy as a differential diagnosis because the bacterium, the reason why it does not affect the CNS is because the bacterium prefers a lower temperature. The preferred temperature for the bacterium is around 32 to 34 degrees Celsius. So the CNS, the brain and the spinal cord are located within the body where the core temperature is more than that. So therefore, the bacterium finds it difficult to survive. So it is a disease of the skin and the peripheral nerves due to the intracellular bacterium, mycobacterium, let's say. Because it's an intercellular organism, usually fomites or inanimate objects do not act as a method of transmission of the disease. The disease spreads by respiratory droplets, similar to TB, COVID, any other respiratory infection. So the source is a person with multibacillary leprosy who is harboring millions of bacilli in their respiratory mucosa, and then they're speaking, sneezing, talking, or even breathing. They put out millions of bacilli into the environment. When these bacilli find their way into the respiratory system of normal people, they get infected. So it is estimated that about 70 to 80% of the population is infected, similar to TB, but only a very small minority will manifest the disease. So only about 10% of those infected will manifest the disease. And also, unlike more well-known respiratory infections like COVID, where the exposure time is quite short, for leprosy, the exposure time is long. So it is estimated that you need to be exposed to someone who can spread the disease for about 20 hours per week and for a long period, about 3 to 4 months. So you see, your casual exposure, like of a doctor, an OPD doctor's casual exposure to a patient is not enough for the doctor to be infected. Now, if you take me, I have been seeing patients with leprosy since year 2001 for the past 22 years. I have been seeing patients. I mean, my contact with those patients is like initially it's the untreated patient. And up until the COVID pandemic, I haven't been using mask. So I consider myself as infected, but not manifesting the disease. Right? Mostly because the time that we are exposed to the patient is short. Like even if you take me, it's about 15 minutes maximum 30 minutes. And again, the incubation period of the disease is long, 5 to 6 years. It could be longer for the ND disease. Actually, there are cases where the incubation period has been estimated to be as long as 20 years. Leprosy, if you think about the pattern, they are no different from the simple Aluhang pattern. So if you think about that, why are we, I mean, just think of this now. Aluhang is something which has actually been in our society. Aluhang is something which has been considered the feature of beauty. Aluhang is the thing that was considered as Gomara, the beautiful. So if you remember, Mahima Bala Gomara Sila, right? So Aluhang was glorified, leprosy was stigmatized. Why? The stigma is due to the disability and the disfigurement, and the disability and the disfigurement are uh, due to the neurological impairment, right? And this disability is due to the leprosy neuropathy, and leprosy neuropathy occurs late. Therefore, early detection and treatment are important. So with this early introduction, shall we move on to the cases? So case 1 is a 13-year-old boy with a hypopigmented patch in the left temple for 8 months. So I would like you to think about the differential diagnosis for this patch and then to think about how we differentiate these conditions. So I will move on to each, as I discuss each BD, I will tell you how to differentiate that condition. So again, there was a question in the pre, like the questions that were forwarded to me, there was a question asking, what is the diagnostic workup of a hypopigmented patch? To answer that question, before we move on, before thinking about a diagnostic workup, think about your history and examination. Most of these hypopigmented patches can be differentiated only by a good history and a careful examination. So I will tell you how to do that. Now, look at this patch of this boy, which has been there, like it slowly enlarged over the past 8 months, but this boy does not have any other patches, right? So first, we'll see what are our differential diagrams. So this is again a young child, a young girl who is having this. Okay, let's go back to our original picture. Look at this one. Now in this lesion, it's fairly well defined. It's hypopigmented. More than that, it's a bit difficult to think about any other features by looking at this picture. But the other things you can do are, like if you think about leprosy, one thing you can do is like touch the lesion. Touch the normal skin and touch the lesion. See whether that lesion is dry. And sometimes, especially the facial lesions, you can ask the patient to go out in the sun for a few minutes so that they start sweating. And then when they come in, just wipe the face and see how the sweating occurs. Usually within these lesions, sweating is less, right? So less sweating, less oily, dry lesions, and also like in the face, in the forehead, it's very difficult to think about the density of hairs. But if you think about the beard region of a male, or even the calf of either male or female, those slightly hairy areas, you will see that the lesions are hairless. But the key feature of leprosy is the loss or reduction in sensation. So how do we look for sensation in a hypopigmented patch? Now, we don't use sharp objects. We use something blunt but with the point. So you can use a toothpick, you can use a ballpoint pen, and also you can use the OPD sheet that you have, the good quality paper, the small sheet you have in the OPD. What you have to do is fold the paper in two and fold it again so that you get an edge like this, right? An edge. So when you get that edge, like you have to sharpen the edges so that you get a very sharp edge. And initially what you do is, like if you take this lesion, you can check, like tell the child, show the child, put your object on the normal skin. Let the child feel how it feels. Get them familiarized with that by putting it on the normal skin first. And once they have had the feel, when they know, and then you ask the child to close the eyes and point out, show me where I'm touching. they have to be able to show like fairly accurately. Like when you put the pointer here, if they show here, that's not sensitivity, right? So you have to make sure that when you put it there, they point to somewhere here, right? About 2 centimeters within the place where you put the pointer. First, you check, ask them to point out to the normal skin so that you know they can do it. And then you put it on the patch. First, you do it here and then you do it here. When you put your object, the paper or the toothpick on the lesion, if they are not able to point out, but they are able to point out when you are putting it on the normal skin, you know that there is impaired sensation. Actually, there is no sensation. Supposing, especially in the face, the patient will point out to you, okay, they will point out, but you are sure that this is leprosy. How do you differentiate? Then what I do is I tell them, okay, I'm going to do 2 at the same time. Just concentrate on the 2 and tell me whether you can feel one better. So what I do is I will put somewhere here. This is number 1. This is number 2. So you put it on the lesion and around the lesion. Number 1, number 2, and ask them to tell you whether they can feel both similarly or differently. So if they can feel the one here better than the one here, then you alternate. Right? This is number 1, this is number 2. Which one can you feel better? So you do it several times, and if the patient is consistently saying that they are feeling better in the surrounding skin than in the patch, you know that there's impaired sensation. So this alone is enough for us to come to a tentative diagnosis of leprosy. Actually, if you can prove that there's definite loss of sensation, that is one major criterion to diagnose leprosy. So that alone is enough for us to come to a diagnosis. The other things you can use as a useful clue are like, especially if you take a lesion somewhere in the cheek, a thickened great auricular nerve or a cervical. If you see a lesion on a limb, especially the upper limb, a thickened ulnar nerve or the thickened medial nerve. Sometimes even the radiocutaneous nerve may be thickened, right? So these are the things that can help in our diagnosis. Right. So what are our differential diagnosis? Now the one on the left is what is usually considered as canulapa. This is called pityriasis alba. This usually occurs in young children around or less than 12 years of age. Usually they have dry skin, and these patches occur when these children with dry skin are exposed to the sun. And they usually occur in the upper part of the face, especially on the cheeks or in the forehead. And these lesions are less well defined, vague lesions. You can see a larger lesion here, but also hypopigmentation here. And if you touch them, they feel dry. All you have to do is look at the rest of the skin. If the rest of the skin is also dry, and if the child has other atopic manifestations like hay fever or asthma, best thing you can do is explain to the parents that this is this. Give them an emollient like aqua cream to apply at night, and make sure that the child keeps themselves away from the sun for the next month or so and see whether the patches disappear. Please don't apply steroids here, because by the time you see this hypopigmented patch, the patch is already healed. In a P. alba, the active lesion is rarely seen. The active lesion is red and itchy. By the time the mother notices this light-colored patch, the disease activity is gone. So steroids will further worsen the disease problem, because not the disease but the issue, because steroids will cause steroid-induced hypopigmentation. So the patch may worsen if you continue to use steroids, even hydrocortisone. So please don't put them on hydrochloric. I mean, I almost never treat a child with P. alba with steroids, even hydrocortisone. All I do is explain to the parents and the child, put the child on an emollient and make sure that they use sun protection. Only thing I tell them is, okay, the other possible diagnosis is leprosy. So if you are not adhering to my treatment, and if you come back again in a month's time with this patch still persistent, I will be doing a bath. So that puts them off. So they usually adhere to sun protection, and in a month or 6 weeks time, the patch will disappear. Then all you have to do is explain to the parents and the child that it may come. The entire thing might disappear when the child is an adolescent, when the skin becomes more oily. Until then, okay, we know why it is happening. Just let the child continue with the normal life, right? The second differential diagnosis is what anybody can diagnose, pityriasis versicolor. So you can see in pityriasis versicolor, the lesions are fairly well defined, quite well defined, and they are as if they have been pasted on the skin, and there's a very mild scaling as if something like corn flour has been spread on the lesion. And the other symptom, and also especially in the case of children, the lesions would be very small like this. Especially the facial lesions in children will be very small like this, right? The other symptom that they will be complaining of is there is itching, especially when the child is sweating or after a bath or a wash. නැවට පස්සේ කසනවා, දඩි දැම්මම කසනවා. And also in versicolor, even if you think about the truncal lesions, versicolor lesions will be like smaller lesions coalescing together rather than one large lesion. Right? What are our other differential diagnoses for a hypopigmented patch? Now this one, the first picture is an achromic nevus. Again, you can see a very well defined lesion, and if you ask them, they will say it has been there since childhood. If it is a baby, if it is a child, the mother might say she noticed this lesion around 3 months, 6 months, something like that. That is not because the lesion started at 6 months, because in a newborn, the skin is quite thin and pink, and the mother may not have noticed it. So this is a birthmark. It's called an achromic nevus. Even though this feature is not very clear here, in an achromic nevus, the edges are serrated, like the leaves of a rose. Rose කොලේ edges here, like a කොහොඹ කොලේ or rose. Right? So if those features are there, if it has been there since early childhood, even infancy, it is an achromic nevus. So all you have to do is reassure the parents and let them go. The second picture shows early vitiligo. You can see the depigmentation rather than the hypopigmentation, and you can see early hypopigmented lesions here and some pigmented lesions within the large depigmented lesion. So early vitiligo is another differential diagnosis. So these are the okay, now because we are talking about children, I will show you some more pictures of lesions in children. Here are actually 5 lesions. Now you can see the well-defined hypopigmented lesion. You can see a few satellite lesions coming out of this pseudopodia and satellite lesions. So that tells you that, okay, the disease is now the bacterium is trying to show its colors, right? So it's beginning to spread. So this child is now actually moving from a tuberculoid leprosy lesion to a borderline tuberculoid leprosy lesion. But look at these 2 lesions. These are very small. All these lesions are in the limbs of children. If you think about leprosy in children in Sri Lanka, 10% of our caseload is children below 15 years of age. And the vast majority will have a single lesion, and that single lesion will be something like this, right? So you can appreciate that those lesions are very vague. The child may not notice it, the parents may not take any notice of it, or they may not consider that this is important, because they may think that this is vertical. Look at the lesions on the back of the elbow. These are two brothers. Both are having lesions on the back of their right elbow. The lesions are more dry. This one is, of course, hypopigmentation is evident, but on the other child, the younger brother, the hypopigmentation is not very clear. But the dryness is there. And if you look for sensation, the sensation is reduced. Okay, when it comes to children, it's a bit difficult to check sensation, right? So you need to be aware of how the lesions look like. These are, of course, teenagers, so checking for sensation was not a problem. And now that we are talking about the lesion behind the elbow, remember the behind the elbow is a common site for leprosy. And also, it is important because you don't see the back of your elbow, so it may got unnoticed for a long time. And also, you know that the lesion overlies the ulnar nerve, which runs in the ulnar groove here. So, if they have lesions behind the elbow, they are very likely to have ulnar nerve impairment. At least early impairment may be there. So, it's very important to detect these lesions and treat them early. Another thing about the back of the elbow lesion is, like, the lesion is overlying a bony prominence. So when there are leprosy lesions overlying a bony prominence, if you knock it against something like this, there will be deep pain. It is not only the back of the elbow, even the wrist lesions, even the lesions on the fingers, like they will say it's painful because if you knock it, if you tap on it, it's called the tap sign. So what we do is we tap on this like this and ask them whether there is deep pain. Sometimes the patient themselves may say, doctor, it's very pain. Another thing about sensory impairment in children is the child may feel that the lesion feels different. Now, if you have ever had any not hypopigmented, but any areas which are with altered sensation, you will feel that it feels differently, especially when, like, in certain instances, sometimes the patient might say, when my clothes come into contact, I feel it's different, right? Especially if an edge is brushing against it, they feel different. Sometimes when the water, like when you're having a bath, when the water is touching your skin, you feel that that place feels different. Children actually notice, and they will try to see actually whether there is such a difference. Therefore, they will be kind of manipulating these lesions. So I mean, especially I think if anybody has listened to lectures by Professor Jani Senevirathan, he always shows a picture with a somewhat big nodule in the elbow with a lesion around that. That's because the child had been manipulating and there was a nodule because of that. So if such things are there, you have to think about a sensory impairment in this lesion. Okay, we move on to second case. This is a 46-year-old male with multiple hypopigmented patches in the trunk, and there's a history of numbness in the medial aspect of left hand, so that is the ulnar nerve distribution. So what's the most likely diagnosis here? Now, one thing I would like you to think of is, like, look at these lesions and think for yourselves, how are these different from vertical? Because now when it comes to multiple lesions in the multiple hypopigmented lesions in the trunk, sometimes it's very difficult to differentiate between versicolor and leprosy. Now look at the lesions here. The lesions are fairly symmetrical. One here, one here, one here, one here, right? So it's fairly symmetrical. So is vertical. these lesions are a little bit erythematous. Erythema is not a feature of versicolor because versicolor does not cause inflammation in the skin. Right? So these are more erythematous, especially the lesions on the waist region, they are erythematous, right? And usually, if you check the sensation, some lesions may show sensory impairment, but some may not. Then, so this patient has leprosy. The other supportive feature here is this neurological impairment in the upper limb. So, what are our differential diagnoses? So, this of course is leprosy. Right now look at this. How many of you would have thought of versicolor here? It's very, I mean, you are really justified in thinking about versicolor in the patient on the left side. Our right side is versicolor. So we went through the features of versicolor. Again, one thing you will notice in the leprosy lesions is the scaling that you see, the fine scaling that you see in versicolor is not seen in the lesion of leprosy. There are other things. On this is one thing I want you to appreciate. This patient has a large patch of leprosy and multiple lesions of versicolor. Because versicolor is extremely common in Sri Lanka, probably the commonest skin disease that Sri Lankans have in the community. I mean, we see patients with coexistent leprosy and versicolor. Now here, of course, it's very clear that these lesions look completely different from the versicolor lesions, but if you are not very sure, what you can do is treat the versicolor for a month with antifungals, no steroids, but antifungals. Get the patient down and see whether there are any remaining lesions. Then it may be worthwhile referring the patient. What do we have here on the right side? It's not an extremely rare condition. There is a very mild cutaneous malignancy called cutaneous T-cell lymphoma, which is a extra, I mean, it's only the cutaneous thing. We usually these people don't get any bone marrow or reticular system involvement. These lesions are usually seen in the double covered area. That means the trunk, the buttocks, the upper arms, right, the upper thighs, the areas which are usually covered by clothing, right? And also see the lesions are in varying hues of brown and hypopigmentation, right? So if patients have this kind of like different, or පාට පෙට්ටිය වගේ දුඹුරු පාට තියෙනවා. Think of, and especially if the lesions are more confined to the covered areas rather than exposed areas, you have to think about cutaneous T-cell lymphoma or mycosis fungoides. The commonest presentation of mycosis fungoides in Sri Lanka is the hypopigmented patch, multiple hypopigmented patches, which have been again there for years and years. Mind you, the youngest patient with hypopigmented mycosis fungoides that I have treated was 7 years. I treated this child at home again, right? So it's not an extremely uncommon condition. We do see them, like actually, I think every dermatologist sees at least one patient every year. So not an uncommon thing. So if you are not sure of the diagnosis, best thing is, like, if you think it's versicolor, treat it. If you think it's not versicolor, just send the patient to a dermatologist. I did not have a good picture, so I didn't include this here. If you all can remember seeing patients with, like, say, if you look at the trunk here, young patients in their 20s and early 30s, they have lesions which look like versicolor, but the midline, the entire midline is white or hypopigmented, like say from here to here, There are no patches per se, but the entire midline like a column is hypopigmented and you have little patches spreading out from that which looks like versicolor. You treat as for versicolor, it doesn't respond to treatment. This is a condition called progressive macular hypomelanosis, which is seen in young adults, especially late teens, 20s and early 30s. Usually, we don't treat them with antifungals. We actually treat them with anti-acne preparations, like benzoyl peroxide, right? So that also is there in our differential diagnosis. Sorry, I didn't have a good picture of that, right? But I think from that description, you may remember like seeing such patients, especially young people. Okay, we move on to case number 3. 48-year-old male presenting with the asymptomatic lesions in the trunk and limbs for the past 5 months. Patient has noticed them for the past 5 months, but probably the lesions may have been there for longer. Which leading questions would you ask? Now, if you check the sensation in these lesions, you may not find a sensory impairment, right? And you also notice that the lesions are erythematous rather than hypopigmented. So now if you have the notion that leprosy is hypopigmentation and sensory impairment, you will not think of leprosy in this lesion. Right? So to answer my questions, which leading questions would you ask? I would ask about numbness or any neurological impairment in the limbs. අතපය හිරිවැටිලද මොනවා හරි අතේ පයේ තුවාල හැදෙනවද මොකක් හරි ස්නායු අමාරුවක් තියෙනවද. So those are the things you have to answer, right? So what are the features that tell us that this is leprosy? Now you see these are plaques. They are raised lesions. They are erythematous. They can be skin colored also. Right. So the main feature I would like you to appreciate here is that there is central clearing within the lesion. Now you see there's central clearing here, even in this lesion, the center is clearing. So when there are bigger plaques, the center is clearing, right? So that it looks like a saucer or a donut or an uldu, right? So these lesions that look like this, thick lesions, ring-like or saucer-like. If there are such lesions and if the patient has even the slightest neurological impairment, think of leprosy. Right? There's a very sure way of confirming the diagnosis. All you have to do is do a slip skin smear, which is available in all skin clinics. It will be like in all possibility, it will be positive. Right? So what are our differential diagnoses for this kind of, now these are actually hallmarks of what we call borderline forms of leprosy, especially mid-borderline and borderline leprosy. Now, actually there was a question asking for pathophysiology of leprosy. I think going into all these details is not so important. But here, while we are talking about this, I'll tell you the most important things about the pathophysiology of leprosy. Now, leprosy is an intracellular bacillus, slow growing, and so it is your cell-mediated immunity which is most important. So if you go back to lesions like this, you have extremely good cell-mediated immunity against lepre. Therefore, you are able to contain the infection to one lesion, which is flat. So you get a lesion at skin level, 1 or 2 lesions. So your cell-mediated immunity is excellent. By the time so that is one end of the spectrum, one different kind of patient, not the same patient. In this patient, the cell-mediated immunity is not so good. So this patient did not start, most probably this patient did not start as a hypopigmented patch. The patient started as this, probably a few flat lesions which then later raised. So here the cell-mediated immunity is neither here nor there, right? So there is an ongoing battle between the organism and the CMI. Both are like ඒක අර ඉස්සර ගොඩක් ඉස්සර අපි යුද්ධ කළා වගේ එක පැත්තක් දිනනවා අනිත් පැත්ත පරදිනවා ඊළඟ වතාවේ අනිත් පැත්ත දිනනවා. So the lesions are unstable like this, right? Then like I will show you lepromatous leprosy later. By the time they have lepromatous leprosy, the cell-mediated immunity against M. leprae is 0. Therefore, the organism has a field day. They are from head to toe, under the skin, diffuse infiltration, and like millions and billions of vessels, right? So that is the pathophysiology. Number of lesions increases with this, the CMI comes down. So what are our differential diagnoses here? There are these conditions called granulomatous inflammation. So leprosy causes granulomata, leishmaniasis causes granulomata, skin TB causes granulomata. So for us dermatologists, those three are our main differential diagnoses: leprosy, leishmaniasis, cutaneous TB, especially what we call lupus vulgaris. So this lesion is more or less like a leprosy lesion, right? So in such instances, we also cannot make a differentiate between these three commonly. What we do is we get the lesions smeared. We do smears for leprosy and leishmaniasis. If either is positive, we know what the organism is there inside, so we can treat. If the smear is not positive, we go for a skin biopsy, and at the same time, we start investigating for these other possible things. Like for TB, you need to do a chest X-ray and a MANTU test, things like that. And also we send now, when we take the sample, we take a bigger sample. When in the biopsy, we take a big sample and send for TB culture and leishmania PCR or culture, so that we can come to a diagnosis quickly. The other thing is the plaque type of mycosis fungoides. I showed you the patch type earlier, the hypopigmented patches. So this is the plaque type. Again, you can see that that donut nature is there, right? But for Sri Lanka, for us brown skin people, these donut lesions should be considered as leprosy. Our first differential diagnosis should be leprosy, not the plaque stage of mycosis fungoides. That is because the plaque stage is extremely rare in Sri Lanka. The other differential diagnosis would be, now this is a case of disseminated granuloma annularis. It's more common in children, but this is an adult. Can you see this donut nature is still there? But the lesions are quite small. The other DD would be treated psoriasis. Now you can see the plaque. Now, of course, you can diagnose that this is psoriasis because the lesions are healed. The silvery white scale is there. But partially treated psoriasis will be difficult to differentiate from the plaque of leprosy. We move on to case 4. This is one of our latest cases. A 43-year-old male from, when I say poor socioeconomic background, this patient is living in one of those, there are these Vatu in Colombo, CMC area. So he lives in one of those Vatu. He has had numbness of hands and feet for the past 2 years, and with spontaneous ulceration of the fingers and toes, and his face has started changing over the past 1 year. And when he had never been to a doctor. He was a laborer, unmarried, living with his only brother. Just the brothers were living there, like they were somewhat isolated from even the community that they were living in. Never been to a doctor. And he came to the NHSL OPD because of this bad breath, bleeding from nose and the nasal stuffiness. Like he was finding it difficult to breathe. That's why he came. Right? So this is him, right? You can see that his face now he is 43. Look at the forehead, how nodular that forehead is, and you can appreciate that he has lost his eyebrows. Eyelashes are gone. See here, no eyelashes. So the loss of hair in the eyebrows and the eyelashes, and the nose looks like it's a bit like Pinocchio, right? A swollen nose. The ears are quite thick. You can see the thickness of the ears. The face looks infiltrated, right? So this is the typical face of lepromatous leprosy. Look at the thickening of the earlobes. These lesions, they had a very high bacterial index. Even if we did this, now you see the skin. The skin on the trunk looks quite normal. But if we do a smear from any of these areas for acid fast bacilli, that is going to be positive. These are his hands and feet, right? So what is your diagnosis? Our diagnosis is lepromatous leprosy. So how would you treat this patient and what public health interventions are appropriate? I'm going to show you the referral. This is something which I'm really happy about. You can see it says urgently, and it gives a very descriptive, this is a very descriptive referral. This referral was written by a doctor in her late 50s, about to retire. Right? See the dedication, the alertness, everything that is there. How nicely it is written. And the date was 26/2/2023, and the patient, this was written urgent, and the patient was asked to go to the clinic the next day itself, and the patient came to us on the 27th. So there was no delay whatsoever. The patient was started on treatment on that day itself, right? So this is what we expect. An excellent referral. The patient was educated about it. The patient was asked to come for treatment immediately, right? So this happened. So how are we going to treat this patient? This patient needs to be treated with NDT only. So I will like later show you the treatment. What public health interventions are appropriate? Now, for this patient who is living in a very, densely populated area, now this patient, when we did his skin smears, now I will talk to you about skin smears also here. Skin smear is like you take make a nick in the skin, scrape the tissue out, and put this, spread it evenly on the slide, and it is stained by the modified Ziehl-Neeson stain for acid fast bacilli. And when you look at it under the oil immersion, you can see the organism. And those are graded according to how thick, how densely you see the organisms. So it is graded from 0 to 6. So for 6 is the maximum, and for this patient, especially the lesions in the anterior axillary fold, the lesions had the bacterial index of 6 pluses. That is the maximum you can get. And about 50% of those bacilli were live, right? Usually you see only a few live bacilli. Most of those are dead bacilli, right? When we do a smear in somebody, like we get a morphological index or live bacterial index of about 1 to 2%. So here we had a 50% live bacilli. So that tells you, okay, look here, this is a patient who is highly infectious, right? He is like a walking time bomb. So he may have infected a lot of people in the surround. So I was really worried. Now, what I was expecting was several other people who are having single hypopigmented lesion. So the first person at risk is his brother. He was examined thoroughly and he has a unilaterally thickened great auricular nerve, and on the same area there's a hypopigmented patch. There was no sensory impairment, so we did a biopsy. So we are waiting for that biopsy. I'm sure that we are going to treat him, right? Then what about his neighbors? The brother is the only household contact. So we can't go now. The most important thing is this patient was so worried. Ane doctor, vatta මිනිසුන්ට නම් දැනගන්න කියන්න එපා. මට වත්තේ ඉන්න දෙන්නේ නැහැ. What can we do? While the patient was in the clinic, we organized to have a house-to-house survey within that vatta in Narayanpeta, and the CMC public health team was very enthusiastic. So we asked the patient to be away from home on the day that we were coming to the area, so that so the patient would be kind of taken out of the picture. So actually, our director, I think he's in the audience, our director, Dr. Prasad Ranavira, the PHI leprosy, the senior PHI, Mr. Vimalaratna, and the PHI leprosy, and I. The four of us went from house to house. And we examined about 50 patients with skin diseases, and out of them, there were 2 patients with single lesion. Right? So probably we have a cluster of 3 persons with single lesions, including the patient's brother and these 2 patients. Now, out of those cases we examined, one patient is already on treatment, the other one is like she is taking a little time because her baby is here. So this is the public health intervention. When you see a highly infectious patient, you have to go and examine the neighborhood, because they may have given the disease to several others in the neighborhood by the time they're diagnosed. But only thing is, we have to make sure that you keep your patients separated. You can't go and tell, okay, so and so is having leprosy, so we are examining your neighborhood. No, you can't do that. You have to preserve that patient's identity. You can't tell anybody that, because your primary responsibility is to that patient. You need to retain that patient. So, but we usually do this as a skin clinic. අපි හැම රෝග දැන බලන්න clinic එකක්. Right? So this is what we did. So we have already started him on rifampicin daily and adaptone, rifampicin monthly and adaptone daily and clofazimine for this patient, which we are planning to continue for 2 years actually, because he has a very high bacterial load. The WHO recommendation is to treat these multibacillary cases for 1 year, but now actually there's a consensus that patients with very high bacterial index from 4 onwards to treat them for 2 years. So that is what we are doing in Sri Lanka. Right. Coming to case number 5. When she came to us, she was 42. She started having numbness of the hands and feet at the age of 30. So a 30-year-old woman having numbness of hands and feet is not a normal thing. I mean, if she were 80, yes, but at 30, it can't be hirivate. So she was investigated extensively. I mean, almost like every 2 years, nerve conduction studies have been done. She had an MRI, she had CT. In 2019, a biopsy had been done. In the meantime, she had a history of recurrent swelling on the face and limbs that resolved spontaneously. So I was the 4th dermatologist to see her. The 3rd person who saw her called me and said, I know this is leprosy, but I cannot prove it. I want you to prove it. So when she came to us, like I was going to do a systematic examination of the nerves. And when I just took her hand in mine, I saw this lesion. Now you can see a demarcation here. This area is lighter than the rest of the skin. And when I asked, what is this? She said, opening උඩ ටික තමයි මගේ අතේ ඉදින්නේ. Usually if it is a edema of extremities, the swelling should be here in the hands rather than in the forearm. But in her case, it was her forearm which was swelling when she went into these swelling episodes, right? And you can see a nice demarcation here. Now, I'm not trying to blame the other three other dermatologists who saw her before me. Because now this was a case like I was so excited. I wanted the trainees at NHSL to come and see this patient. So they were at some important function that day. So I asked them to come the next day when the patient came to start the treatment. The next day, the lesion was not like this. It was more faded, right? For them, it was very difficult to appreciate this demarcation. So I was lucky to have seen her on this data. Okay, so what I'm trying to tell you is lesions can be so subtle, right? And why was she having this swelling? Because she was going into what we call lepra reactions, where there is inflammation of the nerves and inflammation of the existing skin lesion. Right? So the diagnosis here is leprosy with neurological impairment. So the swelling is explained by recurrent reactions, and we treated her with NDTMB plus prednisolone. And while on treatment, she came with facial swelling. Now only I appreciated the fact that she has a lesion on her face. You see? Now the swelling is there. Now this is the normal skin, this is the swelling, erythematous swelling, right? So this now, even though she was telling, mage අතපය ඉදිමෙනවා මූණ ඉදිමෙනවා. The patient will not tell you, mage මූණෙන් කොටසක් ඉදිමෙනවා. Right? But you see, it is like if the doctor sees her during an episode, and if the doctor is observant enough, the doctor would notice that the lesion is this, there is a lesion, right? So actually the previous skin biopsies were negative because most probably these lesions were not there when they did the biopsy 4 years ago. Because you don't see the patient at the time the lesions are obvious, right? So here the lesson to be learned is if a young person has neurological impairment, think of leprosy. As long as they haven't had diabetes for years. So if they have had diabetes for 10 years, yes, you have to think about diabetic neuropathy. But here, you have to think of leprosy. The nerve conduction study in this patient shows involvement of, I think, about 7 nerves. Right? So the mononeuritis multiplex of leprosy is very severe. You will have involvement of multiple nerves. Moving on to the 6th case, a 33-year-old male with a history of he was living abroad in a developed country, never went to a GP. He had numbness of left hand and both feet for the past 4 years. He just kept it to himself. And when he came home, he went to a neurologist. And the nerve conduction study is this: left median, left ulna, right ulna, bilateral, sural, and common peroneal. So 2 here, 4, 6, 7. 7 nerves are involved. Findings support the diagnosis of mononeuritis multiplex. In vivo, the placenta demyelinating changes, MADSAM is the likely diagnosis. This was done by the premier neurophysiologist of Sri Lanka. So anyway, within brackets, Hansen's was mentioned, right? Because Hansen's was mentioned and because there was dryness in the hands and feet, the patient was asked to go to a dermatologist by the neurologist who saw him in the private sector. When she came and sat and said, Doctor, mage අතයි කකුල් දෙකයි හිරිවැටිලා. I noticed that there was a slight redness of both cheeks and a slight coolness at the yellow. That's all. And when I saw the MCS, I thought, okay, this is very unlikely, but I asked the patient to come and get a skin smear done, right? You see, even this dryness is very subtle. Now, just, you know, if you remember the age of the patient, you then appreciate that this foot looks older for this patient. Like he's only 33, but this foot looks like that of an at least a middle-aged person, right? The foot is somewhat damaged. That's all you appreciate. And look at the fullness of the yellow. That's all. I cannot show you his face because he's one of my recent patients and related to somebody in the hospital staff. So I'm not showing you the face, but I actually got him to bring all his recent photographs, not recent, like his photographs from the past 10 years to see whether there was actually a difference in his facial appearance. Actually, they are worsened. So you see, but the bacterial index is +5 even in these dry lesions, right? So this is a case of highly infectious leprosy coming with very mild subtle skin lesions apart from that severe neurological impairment. So he was started on treatment and sent back to his and the country of residence with the referral letter. So far, I haven't heard from him apart from the sister who came and told me that he is on treatment. So we provided him for treatment for 6 months and asked him to go and start his follow-up with the infectious disease physician there. Right? So the lesson to be learned here is multiple mononeuritis multiplex of multiple nerves can be due to leprosy more than being due to diabetes. Again, the story of diabetes. Now, most of the time, when the patient comes with neurological impairment or unhealing ulcers, you invariably do a fasting blood sugar. And if that fasting blood sugar is high, you think it is due to diabetes. But remember, if that fasting blood sugar is the first high FDA, if you are the person who is diagnosing this patient's diabetes, and if that blood sugar is something like 160, it's highly unlikely that this is diabetic neuropathy. For somebody to develop diabetic neuropathy, diabetes has to be there for about 10 years. Another trick I learned from Dr. Siddharth Sekara, consultant neurophysiologist, is like if you're not sure whether it is diabetic neuropathy or leprosy neuropathy, get the patient seen by an eye surgeon. If there is diabetic retinopathy, think of diabetic neuropathy. Otherwise, think of leprosy neuropathy, right? So again, the lesson here is, if you think of diabetes, it has to be long-standing diabetes with other features of diabetic multivascular disease. If those are not there, you can't say this is due to diabetes, right? In that case, your next DD should be leprosy, nothing else. Another one with neurological impairment, the 43-year-old female from Moratuwa. So Moratuwa, I mentioned Moratuwa because Moratuwa is the leprosy Mahadudara in Sri Lanka. 5% of our patients with leprosy in Sri Lanka are from Moratuwa MOH or division of secretary, right? So, one, if you take 20 patients, one is likely to be from Moratuwa. So she had been to a doctor in 2020, several doctors in 2021 with an ulcer in her feet, ulcers in feet with a high fasting blood sugar. That was the first time she was diagnosed with diabetes, but the ulcer was managed as a diabetic ulcer. Then she started developing multiple skin lesions and a left ala neuritis. Has shown so her nerve conduction study shows sensory amplitude not recorded in the left median, left ulnar, and left radial. So the entire left hand is senseless, right? And motor nerve conduction not recorded at left median and left ulnar at elbow. And so the both ulnar and median are gone, and she is completely senseless, and both ulnar and median nerves are completely gone, right? So it shows evidence of mononeuritis multiplex involving left upper limb and both lower. So the both lower limbs are affected. That is why she had the ulcer. Right? So this is her finger, this is her hand, right? So what's the clinical diagnosis? The clinical diagnosis here is leprosy. And how do we manage this patient? Now this patient has to be treated with MDT-MD because of the neurological involvement. He has to be on steroid because this is a short-standing neurological impairment. So we have to try and pivot at least what can be salvage. And here you see her being looked after by the physiotherapist. So physiotherapy is extremely important here, right? So with all those, she's doing a little bit better than this. But again, put yourself in her shoes. What if you had a finger like this, right? I wouldn't wish it on my worst enemy. She is a very pretty 43-year-old, right? With young daughter. So her diagnosis was missed because you thought of diabetes simply because of a high fasting blood sugar, right? So this patient is still under treatment. It's an uphill task even for us, right? Because this finger, we may not be able to give her complete functionality of his hand because it's too badly damaged. So we have to, now my only aim is to make sure that, see how pretty those fingers are, how nicely she is keeping them. Now my aim is to let her preserve that look, not to let her end up with trophic ulcers in those hands, because that hand is completely sensitive. It's going to be a very difficult task. So the MDT packs, these are the MDT packs. This is the paucibacillary treatment. The green pack is, now you see, the rifampicin is given once a month. This is a highly bactericidal drug which can kill 99% of the bacteria with the first dose. Therefore, the moment you are started on treatment, your infectivity goes down. We usually consider somebody non-infectious by the time they have taken treatment for 1 week. This is given for adults above 15 years. This is for children below 15 years. Actually, for children below 10 years, we calculate according to body weight and adjust the dose. This pack is for 4 weeks, and 6 packs of this have to be given to complete the treatment. Then we have the multibacillary. Now, this is given to patients who have 1 to 5 skin lesions, right? Anyone who has 6 or more skin lesions, even 1 nerve involvement or a positive skin smear will be treated with these packs, the red or the brown ones. There you have 3 drugs, rifampicin monthly, clofazimine, and dapsone daily. The red pack is for adults, the brown pack is for children, right? So the minimum duration of this is 12 packs. Usually for people with lepromatous leprosy, we treat them for 2 years. Case number 8, a 43-year-old male with diabetes for 8 years on metformin and glucoside from a GP. His fasting blood sugar has always been around 160. Multiple hypopigmented patches in the shoulder regions and back of the chest. And an area of dry skin in the dorsum of the right foot for several years. And there was numbness of toes on the right foot. And even the dry lesions in the foot were positive for acid fast bacilli on a skin smear. So this is a case of leprosy with uncontrolled or poorly controlled diabetes long standing. Now, These are the lesions. See how subtle the lesions are. Like, but they had a, like, see, these are actually, this is not a very good picture. My camera was not that good. But you can see the lesions, the hypopigmentation, demarcated lesions, and you would expect them to have a negative skin smear. But in this patient, especially this lesion here, the bacillary index is 4+, right? And even that apparently eczematous lesion also was positive for bacteria. So in this patient, when we do a nerve conduction study, if it comes as multiple mononeuritis multiplex, what do? Do you consider this as diabetic neuropathy, or do you consider this as leprosy neuropathy? Because the treatment is completely different. If it is leprosy neuropathy, you need to put him on steroids. He is already poorly controlled diabetes. If it is diabetic neuropathy, you have to look for other features of diabetic microvascular disease and managed as a patient with diabetic neuropathy. So what can I do? Now, my plan of action is I requested a nerve conduction study, didn't put him on steroids. I wrote to his GP and actually I referred him to the diabetic clinic, requesting them, I referred him to the eye clinic, eye hospital, and asked them to look for features of diabetic retinopathy. So based on those, I can plan my management. I'm not going to put him on steroids straight away because if this is by any chance diabetic neuropathy, I'm worsening everything because I'm worsening his diabetes. But if this is leprosy neuropathy, I can get the physician to go for better glycemic control and put him on steroids to try and reverse the leprosy neuropathy. So that is what I'm going to do. Right? So the lesson to be learned here is if you are not sure about diabetic neuropathy and leprosy neuropathy, look for other features of diabetic microvascular disease. This is more for the benefit of public health doctors. His mother and her two sons, two young sons, came to my clinic in Homagama. The mother said, "අනේ ඩොක්ටර් මගේ නම් මේක ගානක් නැහැ. ළමයි දෙන්නටත් තියෙනවනේ. ඒ හින්දා තමයි මං ආවේ." Right? So all three had single hypopigmented patch in the arm. And then there was another son at home and the father. That son had a lesion on the left knee. Father was completely normal. So we expected the father to be the source of infection here. So because there were 3 children involved, we went to the school. We started the inspection in the school, nothing positive. About 2 weeks later, now this is the family. 2 weeks later, another person from the same locality, another lane. Now this is a Vendesi Vatta. So they were on, let's say, 3rd lane, and there was another one on 8th lane or somewhere with a single lane. So now we knew the source is in the Vatta, right? So we organized the house-to-house survey in that entire housing scheme. And the day before the house-to-house survey was to take place, the next door neighbor, there was a elderly person who was actually not living there. The next door lady's brother, who was actually begging in the Homagama town. He was now moribund, like about to die. මැරෙන්න ඕන මෙන්න type එකේ patient කෙනෙක් තුවාල එක්ක. They were looking after him at home. When the health education about leprosy and the house-to-house survey was carried out, the patient was brought to Homagama Hospital. Right? So by that time, the patient was septic, about to die. We were not able to treat him. We just gave him a dose of rifampicin just to make sure that the staff is safe. Then after he died, we examined the entire family, the entire extended family of the next door lady's family. So this index patient's sister and 2 of her sons were positive, right? So that cluster, this is the immediate cluster. So this happened in 2016, and by the time I left Homagam in 2020, I think there were like this large locality. I had treated about 15 people in that locality. So the public health intervention in such an instance is like if you see patients, several patients with single lesion, where there is no source of infection, you have to go to that locality and look for infective source. And so that's the public health intervention that is appropriate. So we did that and we were able to find the index. We are at the moment we are handling a similar case where in the Kalania area we had actually the index. Our first case was a child who was diagnosed at LRH, and that child's mother and brother were referred to us for continuing treatment because they were like older. The next day, we get somebody, another adult, self-referring with a lesion, single lesion, and they all live on the same road, right? So now we need to go to that locality and look for an infective source. So this again is for doctors with a public health interest. So how should we now that brings us to the end of the cases. I will talk to you a little bit about the epidemiology of leprosy. So where should you refer patients? There are dermatology clinics island-wide, so you can refer those patients to them. If you query leprosy, they will be given priority. They will not be put in the waiting list. And in Colombo, you have the Central Leprosy Clinic at room 12, OPD NHSL, which is a walk-in clinic. Anybody can refer the patient, or the patient can self-refer, right? Even from your PP, right? Say now, usually you can't refer a patient to a dermatology clinic from your PP. You have to, that patient has to go through the OPP. Now here for the CSA, the patient can be referred directly to us, even from your PP, right? So please remember that. And we are open daily during working hours from Monday to Saturday. And also we have a WhatsApp service available for healthcare workers. This is extremely new, right? Okay, this is about our clinic, right? And this is our leprosy helpline. Please write down our number 075 40 What you have to do is, if you suspect leprosy, take a clear photograph. Now, when I say a clear photograph, when you take a photograph with your phone, like usually in most smartphones, if you touch, like if you focus and then touch on the screen, that area gets focused and you get a sharp image. Take a photo and enlarge it a little bit and see whether it blurs when you enlarge it. Usually, because when I see a lesion, I always enlarge, right? So I want it to remain sharp and focused even when I enlarge, right? So make sure that it is so. If it is not sharp when you enlarge it, take another. So take a good, sharp, clear photo of a suspected skin lesion. Just that lesion is not enough. And if there are multiple lesions, take multiple photos. Give us a short history, age, sex, duration, and please tell us the location if the location is not obvious in the picture, and associated symptoms like itching, numbness, any other things that you think appropriate, and send it to us. Usually what happens is the messages that they are asking for advice will be forwarded to me. So I will be usually looking at those. So you will get a response within 24 hours, right? Unless it's a weekend. Even during weekends, I'm usually active on WhatsApp, right? So please remember, now we are introducing all these to make sure that the backlog of patients are actually diagnosed. So let's go and see what this backlog is like. So what's the situation of leprosy in Sri Lanka? This is an old map. I'm just putting it for you to appreciate a few things. Now, Sri Lanka achieved the WHO target of eliminating leprosy as a public health problem. As a public health problem. That was achieved in 1995. So when we said api laduru turang kala, everybody expected large root to be not there, 0. But the definition of elimination of leprosy as a public health problem is a point prevalence of less than 1 per 10,000 population. So even if you make a crude calculation, you can have 2,200 patients and still be within this target, because now our population is 2.2 million. And even this target was achieved only at national level. Now these areas it was achieved, but these areas, you see the discrepancy in Nuerenia for 100,000, it is 1.7 per 100,000 population. But in Batiklo, in 2013, it was 28 per 100,000 population. So you divide it by 10, 2.83, almost 3, like almost 3 times that national level. So at subnational level, we had not achieved this target, and WHO was also not very interested in doing this subnational level. So we were happy. We were just giving the WHO their data. We were very happy. Okay, we have achieved the target. But what happened was, general public, the healthcare workers, everybody thought leprosy is no longer there. It was not there, not in their differential diagnosis. So in the meantime, we were diagnosing about 2,000 cases from year 2001 up to 2014. There were about 10 per 100,000 population. Then from 2014 onwards, we started seeing this gradual downward trend. This was seen globally also. So we think this was an actual downward trend. Then in 2000, from 2020 and 21, with the COVID-19 and all these other issues, our diagnosis of detection rate came down drastically. Now it was 4.6 in 2021. We have gone up in 2022 thanks to all these health education programs that we have been doing. So now the big task in front of us is to find those cases that are missing, right? This is very important. We have about 10% of our patients are children below 15 years of age. What is important here is, if a country has a high child rate, that means there is ongoing transmission within that society and community. Therefore, Sri Lanka is probably within the top 10 countries with high child rates. The global child rate is about 4%. So globally, we see about 200,000 new cases. Only 4% of them are children. But for Sri Lanka, it is 10%. That means we are still spreading the disease within our community. So we need to do something to bring that down. So this is our new strategy. We have gone to the subnational level. This is our new leprosy risk map. The areas marked in red are the areas where the child rate, there are children, still children are being diagnosed. So the entire Western province, almost all the divisional secretariat divisions, children are being diagnosed. Therefore, we are still transmitting the disease within the community in these areas. Then we have these orange areas where for the past 5 years, no child has been diagnosed. So it's only in adults. So ongoing transmission, we can say transmission has been curtailed in those areas. So we have 177 DS divisions, such DS divisions. Then we have these green areas where for the past 10 years, like the light green areas, for less than 10 years, we haven't detected a single case, either in children or adults. The dark green areas, for more than 10 years, we have not detected any child or an adult with leprosy. So this gives us a better hope. It shows us that in Sri Lanka, there are areas where leprosy transmission has been stopped. But there are so many areas where still the disease is active. So these areas, the red areas, we have to go and educate everybody. We have to educate children, we have to educate schools, adults, everybody, the general public. But in these areas, we only have to, the healthcare workers have to be vigilant. Okay, leprosy could be there, right? So in such areas like in the northern province, if the healthcare workers are vigilant enough, we can detect any sporadic cases. But in these areas, especially the red areas, everybody has to be vigilant. The general public has to know about this. So this is how now we are going to target our strategies based on how bad the risk is, right? So I'll just show you the phases of elimination of leprosy in phase 1. Now, in those red areas, we are still in phase 1 until interruption of transmission. So that is no new locally acquired cases among children for at least 5 weeks. So we are still in that phase in about 50 DS divisions. Then once you have achieved that, then you go into the phase 2 where there are no child cases, and for 3 years you need to have no adult cases on. Once you have like no cases, no adults, no children, then you have to wait for another 10 years before you are certified as free of leprosy. So this, now, if you look at this, we will not be able to just total these number of years. So you need 18 years minimum for the country to be certified leprosy free. So this will probably be a target for 2050 rather than 2030, right? But unless we get ourselves on that road now itself, we will never achieve this target, right? That is why we want the support of everybody, all of you, to take us towards this road, right? Okay, thank you so much for being with us, and I think I can answer a few questions. Is there any? Yes, I can see one question from Dr. Chintana. What would be the management of a pregnant lady with leprosy? The management does not differ. A pregnant lady, whether it is the first trimester or the third trimester, irrespective of the trimester, we treat them with the MDT based on the classification. If it is TB, we treat for 6 months. If it is MD, we treat for 12 months. The 3 drugs, dapsone, profesamine, and rifampicin, are not contraindicated in pregnancy, so they can be treated. And they have to be treated, especially towards the latter part of the pregnancy, because if you don't treat them after pregnancy, when their immunity is recovering postpartum, they are very likely to go into what we call lepra reactions. Therefore, they have to be treated. So the management would be treat with MDT according to the classification, right? Any other questions?
Yes, madam, there are another 2 questions there for you. The first question is, do we expect nerve thickening in all type of leprosy?
Yes, nerve thickening can be seen in all types of leprosy, right? Actually, in paucibacillary type of leprosy, we think of more towards having single nerve lesion rather than what we call multiple mononeuritis multiplex, or what we used to call peripheral neuropathy, glove and stocking type of sensory impairment. So towards tubercular leprosy, you may get nerve thickening, you may get involvement of one nerve. But towards a lepromatous leprosy, you get more a picture of what we call a peripheral neuropathy or mononeuritis multiplex of multiple nerves. Still, nerve thickening can be there.
Okay, madam, the last question, it's about the MD part 2 spot. If you're given a patient with a leprosy, then how do we proceed, madam?
Right. Again, it depends on the type of the patient, the type of leprosy, and what questions you are asked, right? So basically, I'm not very familiar about how MD Part 2 spots are being carried out. Like, if the doctor who asked this question can contact me directly, I think I also need some more input from them before I answer this question. So, Tahan, if you can get this doctor in contact with me later today, I can discuss this with the doctor concerned.
Yes, madam. We have given the number to contact. So Dr. Ishara, I think, can contact through that number, and we will contact you in the evening, madam. So
You mentioned about the skin condition occurring in a young child, versicolor-like lesion with entire midline. Yes, that is called progressive macular hypomelanosis. Just Google it and see, right? Progressive macular hypomelanosis.
okay, madam. Those are the questions that came through for today. So
Yeah, I think we have come.
yes, madam. Thank you very much for coming today. Behalf of the Sri, I would like to appreciate your effort that you come to our office today, to our studio today, and given us a very informative and very wisdomistic lecture. And we would like to share hands with you, and we would like to join hand with you in future also in events like today. So thank you very much for all the participants who came and got the wisdom from madam, as well as we will be giving you the link for the e-certificate also in a while, and you can fill the e-certificate, fill the form, and also obtain the e-certificate also. And moreover, if there are any more questions regarding leprosy to send to madam, you can send them via the email address that we have provided in the WhatsApp group also, and we would get back with you in the near future. So thank you very much for joining today. Thank you again to Dr. Indira Kahavita, the consultant dermatologist in the leprosy campaign, as well as thank you all for joining with us, and hope to see you again in next Sunday also with another very in-depth program. Thank you very much.